You can see the motion there. The motion is that advances in diagnostics and new therapies will reduce the need for allogeneic stem cell transplantation in AML. And we're going to ask the audience to firstly vote on their opinion before the debate starts. So just to emphasise, agreeing with the motion means you think there will probably be less of a need for transplant. Disagreeing with the motion means as many, if not more, transplant. And you're welcome to say you're not sure as well. So if we could vote now. Oh. Absolutely perfect. We're going to run the debate by, I believe it's Oxford Union rules, so it's going to be each of the opposers are going to have 10 minutes, which is going to be rigidly enforced. I'll give you a warning when we get to 1 minute to go. We're going to alternate proposer one, opposer one, and so on, and then we'll have a 2 minute each sum up and before a vote at the end. So the whole thing we should be done in just under an hour. To propose, David from the Royal Marsden.
I'm going to talk about advances in diagnostics and how they reduce the need for transplant. And I think the key area is that transplant in CR1, because of course that's upfront risk. I'm not contesting transplant in CRT, where I think there's a clear benefit. And I'm not talking about experimental programs. Obviously, Charlie's done an excellent job herding the cats of the transplant world through the impact program to do some excellent trial work in transplantation. But I'm talking about standard transplant. And I'm going to talk about the genetic risk assessment, MRD, and a little bit about tissue typing. So obviously, poor risk cytogenetics, you know the bad players, the MLLs, the 5s, the 7s and 17s, and obviously these define patients as high risk up front, and there's evidence from a number of sources that patients benefit from allograft in CR1. However, they're not a homogeneous group of patients. About 70% of the complex karyotype AMLs have a TP53 mutation, and I would argue from this data, which has already been shown from Ellie Papamanuel, that this group is futile or dismal. And this study was published in the New England Journal, and they classified patients into TP53, wild type or mutant, complex or not. And obviously, although the outcomes aren't fantastic if you've got a TP53 mutation but no complex karyotype, it's not futile. However, in the blue curve, your TP53 mutant complex karyotype, there's no long-term survivors or minimal long-term survivors. And I just point out that the HD98A trial, from where these patients were derived, and the AMLSG trial, the intention to treat was intensive chemo for allograft. So the intention to treat based on the cytogenetics for all these patients was intensive chemo and allograft. Yes, I'm not sure we should be offering what I think this data shows to be a futile treatment or nearly futile. I know Panos from UCH mentioned that they have 1 out of 44 survivors with TP53 mutant AML, but they were not looking at those with complex karyotype only. So I think we should divide the poor risk into poor risk, which might benefit from a transplant, where you have maybe a 20% cure rate, and the dismal risk, where allograft is futile or near futile. And the other bit of the genetic workup, which is going to become increasingly relevant in the UK with the setup of the GLHs, is looking at another entity, CBP alpha double mutation, and work from Richard Schlenk and colleagues shows these patients do not benefit from allograft in CR1 in terms of there is not better overall survival. These patients can be salvaged if they relapse, and they can get an allo in CR2. And that's really the key point, that many of the patients, you can, if they have a non-transplant approach up front, can get salvage chemo and a transplant in CR2. So that's two examples of patients who I think should not have allo in CR1. And then the other thing which has been widely discussed, and I don't want to go over this too much, is the effective MRD testing. And obviously there's David Grimwade's NPM1 monitoring, and then there's Sylvie Freeman and others' flow for the NPM1 wild type. And I just mentioned this has been shown a lot, but clearly FLT3 ITDs, which were previously transplanted a lot, if they are MRD negative in the blood, their relapse risk is only 35%. So I think we should not be transplanting NPM1 mutant patients who are FLT3 ITD if they are negative in the peripheral blood after 2 cycles. And that takes out 85%-ish of NPM1 mutants using the PCR, i.e. only about 15 to 18% of them will be MRD positive. And of the ones who are MRD negative in the blood, and they then have persistent disease or molecular relapse, they're highly salvageable from the data that Richard Dillon has given me. So I think he said the CR2 rate is about 88%, so they're highly salvageable. So I think this strategy avoids, or rather reduces, transplant for the NPM1 mutants. Similar data were presented from the French, and again, this has already been covered, but I just make the point that although they weren't decided on transplant or no transplant, depending on the MRD, those who were had a good NPM1 MRD response had very good survival without a transplant. And then there's the other side to the coin. There's the flow-based MRD assessments for the NPM1 wild type. And if you look at figure B here from Sylvie's excellent paper, that the MRD negative ones have very good overall survival, while the MRD positive ones have less good survival. And then they've done what I would accept as a preliminary analysis, looking at the role of transplant in those patients. And there was a trend that allograft is not better for the MRD negatives. And when you censor for transplant, the MRD negatives really have very good outcomes. Again, the numbers are small, but I think this group should not have an allo in CR1. And this data has been produced in a similar manner by the Dutch, Belgian, Swiss groups, Vesuis, Kalin et al. If you look in the figures there, on the left is those who are flow MRD negative in A and C on the left, and on the right it's those who are MRD positive, and then looking at whether they had an allo or chemotherapy as consolidation. And if you look at figure C, you can see that those who are MRD negative who had an allo had very similar outcomes to those who had chemotherapy or actually an autograft, whereas those who were MRD positive after cycle 2 on MRD had a better outcome with allo. But again, I think some of the patients who were previously intermediate risk may have been transplanted unnecessarily. And interestingly, and again, this is another key point in this paper, when you looked on multivariate analysis, and one of the factors they looked at was allograft versus no allograft, when you look at the overall survival, it was not different. So this is because although the relapse risk is lower with an allograft, the non-relapse mortality is higher. And again, I think this is data pointing away from allograft. They were allografting both intermediate and poor risk patients in this study, and there were a lot of allografts, and there were a lot of sibling allografts here. So it wasn't that they were doing lots of high-risk mud allos, but no survival advantage for allo and CR1 overall in multivariate analysis. And obviously genetics has not just improved the testing of leukemia, but it's also improved the testing of donors. And this is a study, Chloe Antheus kindly provided this study, where they're looking at advanced tissue typing using genetics, and they're comparing, these are all mud donors 10 on 10 or better, and they're looking at DPB1 matching as well in association with CMV. But the point I make, if you look at curve F, so if you have a 10 on 10 mud donor who's got a non-permissive DPB1 mismatch, who is CMV mismatched, their 5-year survival is 17.5%, which is not fantastic. And I think we, going forward in trials, need to very closely define what is an acceptable donor. I think just referring patients for allograft is not acceptable now. I think we have to really tighten up on what we define an acceptable donor is, because of these large differences. Whereas if you have a 12 on 12 mud donor who is CMV matched, you know, you're looking at almost 62% 5-year survival. And I just make the point that there are improvements in survival with intensive chemo. This is from the AML 17. The patients who had FLAG second cycle had a 4-year survival of 28% with no allograft. And that's sort of better or comparable to the less good mud donors. Thank you.
And now Rachel Prothero to be the first to oppose the motion. Thank you, Rachel.
We're undoubtedly entering an incredibly promising new era of therapeutic and diagnostic advances, and we don't dispute that. What we do refute, however, are the proposition's claims that these advances will lead to a reduction in the need for transplant. And I say this because, as we've heard over the last 2 days, AML is a heterogeneous condition. It is polyclonal. It has the propensity to mutate and relapse. And there is a need for transplant based on risk of relapse. I'm going to show you some diagnostic advances, some of the data which we've already seen over the last 2 days, and some of the data which we've just seen David present. I'm going to look at some efficacy data from the new therapies in a transplant-eligible population. And then we're going to hear from Amit, who is going to take forward our vision as the opposers of this motion, in that we can combine these therapeutic diagnostic advances to improve the outcome for patients with AML. So this is the proposition's case. It's quite simple. You have diagnostic advances plus new therapies equals a reduction in the rate of transplant and transplant activity even before the ink is dry on the FDA approval, just as you can see here. And in fact, yes, this did happen. But Mike and David want to roll the clock back 20 years, in fact, don't we all, to this scenario when, even before the FDA had improved imatinib, because there was clinical recognition of how it was going to reduce the need for transplant, transplant activity had plummeted. Has the same happened in AML? Of course not. CIBMTR data here demonstrating an ongoing rise in activity for transplants in AML, demonstrated here in the context of the first of many FDA approvals for new agents in the disease. And why is it different for AML than it is for CML? Because, and this is, I think, the 4th or 5th time we've seen this slide, and I apologize for that, but the message is really clear. AML is not one disease, and you can see the different cytogenetic and molecular classes and all the associated co-occurring mutations. And currently, despite the molecular heterogeneity of AML, only a very small fraction of the identified mutations actually inform our clinical practice in any way. We can see here, with the patients representing the vertical bars, mutations, the horizontal, that when we have 7 patients with AML on the ward, we actually have 7 different diseases. Now, I'm sure Mike is going to tell us that in order to treat these patients, we need to target laser-focused precision therapy. And we could do that. But as Lynn Queck has already shown us, AML is a mutating and relapsing, and I'm sorry, the word monster has clearly wandered off the page, because we can see at diagnosis we have a polyclonal beast which mutates and relapses, and at relapse we've got a different beast. So if the proposition wants us to go based on the molecular profiling at diagnosis and pick off with targeted therapies these molecular mutations by diagnosis, as we can see here, in 80% of patients at the point of relapse, the molecular profile of the mutations will have changed. Now, this blows a Titanic-size flaw in the proposition's case. And it brings us back to the risk of relapse. How do we calculate the risk of relapse? Well, that really is a balance between looking at a number of factors at diagnosis, as we've heard from David already, incorporating numerous different measures of response to therapy and minimal residual disease assessment. And we've heard already from a number of speakers over the last 2 days that on the basis of ELN guidelines, transplant is beneficial in those people with non-favourable AML in CR1 with a relapse risk of over 30 to 40%. Now, we then decide who is eligible for transplant and needs a transplant on the basis of weighing up the risk of relapse against the toxicity of the transplant. And I'm going to come back to that at the very end. We can use molecular diagnostic advances in order to not reduce the risk of transplant and the need for transplant, but rather refine the need for transplant. And this is, again, data that you've seen before over the last 2 days. We've heard of this group of individuals, so conventionally on a diagnostic risk assessment, they fall into a poor risk category, they're FLT3, NPM1 positive, but being MRD negative gives them a lower risk of relapse, and most people from the voting we did earlier would not transplant those patients. And that is the argument David made. But there is a converse argument when we look at this group of patients also. So we can also apply MRD analysis to refine need for transplant. These would conventionally be regarded as good risk patients. They are FLT3 lacking, NPM1 positive, but they're MRD positive following 2 induction cycles and have a high risk of relapse. And on this data here, I would reinterpret the version David presented. We actually see that for those people in which there is not a significant reduction in NPM1 MRD, that there is a definite survival advantage for transplant. The need is not reduced, just refined and better understood. And we can apply this refinement of understanding need for transplant in risk-directed therapy, where we can also show a benefit for transplanting patients who would otherwise be considered as favourable risk. Let's look at RUNX1 MRD analysis. When we identify patients who have persistent RUNX1 MRD and would be classed as high risk on the basis of that, we can see that those patients benefit from transplant in first remission with lower relapse and higher overall survival compared with chemotherapy alone. And let's now turn to the therapies that have recently been approved. I've summarised all 8 of the recently FDA-approved therapies here. But as David asked, we're only going to look at those patients in CR1, so I'm going to ignore those drugs used in a relapse refractory setting in a moment. I'm also going to look at the drugs used in transplant-eligible populations. So I'm not going to focus on those drugs used in a non-intensive setting or in older patients, although as we've already heard, venetoclax from these data identified 10% of patients when used in this setting that became transplant eligible following use of the drug. So the drug is not reducing the need for transplant, but making patients transplant eligible and therefore offering them the opportunity of the benefits they can reap from transplant. But I'm not going to look at that anymore. I'm also going to take out the data from phase 1-2 trials where there's safety endpoints, not endpoints of long-term disease-free survival and cure. And I'm therefore going to be left bizarrely with the drugs that are also NICE approved. And I'm going to whiz through these at breakneck pace. So let's look at midostaurin. We've all seen the advantage in terms of overall and disease-free survival from using midostaurin with induction therapy. But look, 57% of patients also had a transplant. So this isn't a study demonstrating the benefit of midostaurin in reducing the need for transplant. There was no significant difference in the transplant rate between the two groups. And if we look, we can see that the benefit for midostaurin persists in this landmark analysis from transplant, but only when transplant is done in first remission. There is no significant difference in the relapse rate between the groups. So we really can't say that the need for transplant is reduced. What we can say, however, is that midostaurin administered pre-transplant improves outcome post-transplant, possibly due to lower MRD pre-transplant. And that's going to be a recurring theme, which we're going to see again here when we look at Vyxeos. Again, impressive data. First of all, higher CR rate, potentially making more patients eligible for a transplant. There's no evidence that it reduces the need for transplant. Yes, overall survival is improved, but look at overall survival from transplant when censored at the time of transplant. There is evidence of persisting benefit, possibly, again, due to lower MRD at the point of transplant, and also due, perhaps, just like we saw with venetoclax potentially, lower toxicity, making patients fitter, in better nick when we transplant them. So, really, no evidence of reduced need for transplant. And finally, Mylotarg. Here we see benefit in event-free survival, that was the primary endpoint, but no difference in overall survival, unless we look at subgroup analysis, where, unfortunately, we see that there is a benefit, but in the patients we're not going to be transplanting. I'm about to stop talking. So far, I've shown you no benefit. And in my last two slides, very quickly, let's look at the toxicity profile. The proposition, if they're going to cure people only with these drugs, they're going to need to use them in combinations. We've already heard about that. And we should not think that combinations of these drugs will be harmless, particularly if they're used for long periods of time. What are those overlapping toxicities going to look like? We don't know. What we do know is that the toxicity of transplant, and that is ultimately why the proposition want to reduce the need for transplant, because of the toxicity. What we do know is that there's a 10% reduction in recent decades from TRM with a MAC. We now can do reduced intensity condition transplant, and the jury's still out on whether you need a MAC or a RIC to cure AML. And we can use reduced toxicity rather than reduced intensity conditioning, such as thiatipa, fludarabine, bisulfan, really low TRM, no reduction in relapse risk, and amazing survival. So actually, rather than reducing the risk of AML relapse with these drugs, we're shifting that arrow to reduce the toxicity of transplant, and I leave you with the statement that there's no evidence that these advances reduce the need for transplant. Thank you.
Thank you, Rachel, who yesterday was at pains to deny rumours that she used to be a schoolgirl debating champion. Mike, could I ask you to respond to that? Good luck.
Yeah, thank you for that. I'm probably not the only one in the audience that felt I was just listening to a party political broadcast. Do not be confused by the amount of data you're bombarded with. It's all fake news. So, we've looked a lot at Kaplan-Meier curves, and as I look around the audience here this evening, I noticed that it's many of the people that are very much pro-transplant who've decided to remain and support their colleagues on the podium here. And that's worthy and that's grand. But we're not just interested in Kaplan-Meier curves, we're actually interested in patients. And this takes me back to an anecdote. This time of year, everyone's teams are thinking about organising Christmas do's. And our last Christmas do, I remember one of our nursing colleagues, a little bit worse for wear, you're allowed to say it, jumped up on the table and shouted out, "We're the best transplant unit in the world!" And everyone started cheering, which I thought was great. But whenever anyone has had a drink, you know that perhaps your attachment to reality sometimes eludes you. And so we're not the best transplant unit in the world, but we do a lot of transplants at our centre in Manchester. And sadly, I don't think a week goes by in my life where you're not touched or involved in somebody's life that you've completely destroyed by an allogeneic transplant due to chronic graft versus host disease. So we need to think about the destruction and toxicity of transplant and avoid it wherever possible. So David has already given you a really nice overview of how diagnostics are pivotal in terms of identifying those patients who can escape this toxicity, And we've also seen many of the slides that I'm going to present to you highlighting the fact that we've had a tsunami, an explosion of new therapeutic agents that are transforming the outlook for our patients with acute myeloid leukemia. These are those that have been licensed by the FDA. Sadly, a fewer cases have been licensed by the EMA. Now, I could probably make a strong argument for virtually all of these drugs, but I'm going to concede a few to Rachel, being generous, and only concentrate on perhaps these 4. And you'll notice they're not really the ones that she was considering. Now, whenever you go to a talk in terms of who are the patients with acute myeloid leukemia that should have a transplant, the core binding factor patients are always considered. You know, there's always this discussion about KIT mutations and the high relapse rate. So generally speaking, I think we're coming from a starting point where CBF patients often are in the mix for considering for allograft. This is an adaptation from Jan Cornelissen, published only a few years ago, highlighting the fact that a proportion of patients with CBF have a high relapse risk and therefore should be considered for allograft. Well, this is very old data now, going back to a combination of many of our previous studies showing that sequentially, with the application of new refinement of therapy, and particularly the addition of Mylotarg, as each decade a new trial has gone by, we've seen survival improving without transplant. And then if we look specifically at the patients who received Mylotarg at induction with high-dose Ara-C consolidation, there's a 90% 8-year survival rate. Unequivocally, these patients should never go anywhere near transplant. The meta-analysis, you've seen this slide already many times, highlights the fact that that's a thing of the future. And similarly, as David's already told us, for the minuscule patients that don't require the transplant, we now have MRD as a means to evaluate whether that's going to be necessary in the future. So last time I looked at the WHO classification book as well, I understand that acute promyelocytic leukemia is also a form of acute myeloid leukemia. And these are slides that Nigel presented at ASH, highlighting that in AML-17 we had nearly 200 patients who had idarubicin-based therapy. Very few relapsed, 30 in fact. One of them couldn't receive treatment before they could have any salvage chemotherapy, but all 29 that received arsenic treatment achieved molecular remission. Now, we used to think that maybe a transplant was needed to salvage patients. And in fact, we had a gentleman here today who's made it known that he's been successfully salvaged with allogeneic transplant following acute promyelocytic leukemic relapse. But you'll see from the NCRN data that those remissions were durable, and that half of the patients had a transplant, half didn't have a transplant. And as you can see, the survival from relapse in APL is phenomenally good. And the only patient really that died from a transplant. So I would have to concede that if you look at the EBMT activity data, I know that I've now just over 50. I'm having to wear glasses, but I thought I saw on Rachel's slide that there was actually a slight dip in the activity of the number of procedures being done for acute myeloid leukemia. That could be wrong. But I would concede the fact, if you look at this, there's been a massive explosion in terms of the utilization of transplant across the board. This touches based on Goulam's point that we have an aging population. So there's no doubt transplant has been dramatically expanding. And within that, there's a proportion of acute myeloid leukemia. But our new treatments are perhaps the future. So this is the EBMT data that's only published online this year, which I thought was compelling, thinking particularly with respect to venetoclax. So you go to transplant meetings and you'd often hear about the importance of how transplant's a modality that can be utilized for patients up to the age of 80. Well, this is specifically looking at the group of patients who are over 70. So a highly selective group of patients with a median age of 72. And what this shows you is there's a 40% incidence of significant graft versus host disease. There's a near 40% toxicity with death. The survival curve is obviously relatively poor, and the survival curve with good quality of life in the absence of GVHD is truly atrocious. So I think this is delineating the fact that the over 70s should not really be going towards allograft with the advent of venetoclax therapy. We've seen this already. Rachel made the point that as Courtney highlighted to us very nicely this morning, that 10% of the patients treated at the MD Anderson who were originally not thought to be eligible for allogeneic transplant had venetoclax therapy. But actually, that's surely got to be a reduction. Most of the studies we would see are from a phase 2 basis of patients not fit for intensive chemotherapy. Probably more than 10% would normally go to allograft from the MD Anderson. Just joking. But so if you look at these two head to head, going forward with transplantation in the over 70s on the basis of EBMT data, highly selected, highly fit patients, your survival is terrible, and you've got graft versus host disease in a significant proportion of the patients. Using and hopefully being able to extrapolate the findings of now using venetoclax, survival is markedly improved in the absence of GVHD. Finally, maintenance therapy. So Alan Burnett presented our NCN experience in 2015 at EHA, highlighting the fact that you give subcutaneous azacitidine at the end of intensive chemotherapy. There's no improvement in terms of overall survival. But for the MRD negative patients who perhaps have more sensitive disease, there's an opportunity for them to be salvaged. And there was a significant survival advantage going from 13 to 40%. So we get a hint that there are patients who will benefit from maintenance therapy. Gert already highlighted the fact the HOVON experience showing a very clear, distinct improvement in terms of disease-free survival, but not yet translating to an overall survival, perhaps due to salvage therapies or other confounding factors. We've heard on multiple occasions today the fact that the Quasar study has had headline results indicating a significant improvement in terms of overall survival. So I'll leave you with my final slide. Trying to keep to time, I think there's compelling evidence of 4 drugs that unequivocally will reduce the need for allogeneic transplant in acute myeloid leukemia. Thank you.
Final speaker is Amit Patel to oppose the motion. Amit.
Thank you very much, Mike, for letting us know about all the patients that we don't currently transplant, and therefore we would not be interested in transplanting. But if we talk about the need for transplant and how that might change with the advent of all the new medications that have come online both in the US and the UK, I think there's a couple of important points that were pointed out this morning, and that is you need survival data. You cannot decide suddenly that a treatment is better than another treatment because the response rate's better, there's a higher MRD rate, there's a higher event-free survival, progression-free survival rate. All of these are important on the journey to long-term survival data, which actually is limited in a lot of the drugs that are available. And of this list, Rachel's already alluded to the fact that really only CPX with midostaurin are probably the ones that will be applicable to patients that you would want to transplant. The others are in potentially relapsed refractory patients at the moment, or in patients that are unfit for a transplant. So if you consider that if you have a relapsed refractory patient you can salvage, well, that's a patient you wouldn't have transplanted that you are going to transplant. If you've got somebody who is unfit for a transplant that you have somehow got into a complete remission, perhaps a molecular remission, which would of course improve your transplant outcome, then I think you've increased the need for transplant rather than reduced the need for transplant. And of course, if you've improved transplant outcome so much that your 100-day mortality or your non-relapse mortality has gone down to around 10%, then I think you can transplant more people. And let's just put some flesh on that argument. So at the moment, the paradigm here is very straightforward. Patients who are fit for transplant could potentially get one of these new agents. We've seen already venetoclax has very good response rates, which makes them fit enough to go to transplant. And we can see if you're in the relapsed refractory setting, you're incurable without a transplant. So if you can be salvaged, you'll go to a transplant. And let's look at the UK, because of course we always worry about elderly patients, patients where the disease burden is highest. And that is true, that most patients in the UK with AML are old, with median survival of 85. And actually the transplant rate per year is running about 18% if you take all the cases that are diagnosed. And that means that actually when you look at the BSBMT data, so this is all transplant centres in the UK, the transplant trend is increasing, not decreasing. If we then look at the life expectancy in the UK, actually women have a life expectancy of 85, which is the average age of onset of AML. Look at the boys. You're managing to make them live longer than they would otherwise have been, so they can get leukemia. No, but you can see that actually the average age is high, and so you need to think about what you're going to do about these patients. But what's important to point out is that we're not going to transplant these patients, and therefore any new drugs directed against this group are not going to affect transplant numbers. So if you're a transplanter in the UK, you might say if you live in one part of the world, maybe 60 is your upper limit. If you live maybe in Oxford, parish might say, well, maybe 75 is the limit. But in any case, the disease burden, so the number of patients you could treat, is much higher in the older group rather than the younger group, where we heard much more about using molecular diagnostics to decide patients that perhaps might be MRD negative at various time points that you might not want to transplant. So if you can increase the number of patients in this group that might be suitable for transplant, you'd increase the number of patients you're transplanting. And actually, if we look at the performance status of patients with AML, actually, look, this patient's 70 to 74. Half of patients have a performance status of 0 to 1. So, in fact, you could consider transplanting this group of patients should they have other parameters that are suitable. And look at the data. Well, the data shows that we are not only increasing transplants year on year, we're increasing the number of older patients where the disease prevalence is much higher year on year, including patients over 70. And in fact, some of the newer treatments are going to make us transplant more patients in this disease area, particularly Vyxeos. But I just want to make a point about the gemtuzumab story. Gemtuzumab's been available for a number of years now. So if we were going to see a negative impact of gemtuzumab on transplant practice, remember, we aren't going to transplant patients that are good risk disease to start with. And it's controversial whether intermediate risk disease benefit is sufficient in the meta-analysis to warrant use. Certainly, we've seen that the data I've shown you, transplant activity is increasing despite availability of gemtuzumab. And in fact, if you relapse after being exposed to gemtuzumab without a transplant, you're not going to survive. That's this group here. So a transplant is important both upfront and also for salvage. We've seen the midostaurin data already, and I think it's important to point out here that patients will benefit from a transplant if they are able to get to a transplant in CR1. The benefit of midostaurin really isn't seen outside that setting in that study. We've heard lots and lots about venetoclax. Well, let's just have a look at this data a bit more carefully. Well, these are elderly patients, 65, which you could transplant, with performance statuses of 0 to 2, you could transplant, but 70% needed discontinuation. And if you look at the CR rate, which is very high, if you can get somebody to transplant, you will. Oh, look, 15% did go to transplant. So in fact, you might find that of the number of patients at risk here, this is 16 patients, this is 15 patients, well, at this time point, maybe these patients are alive because they've been transplanted. So in summary, the venetoclax story probably will enable you to transplant more patients if you can get them to the procedure in a fit state. What about the CPX story? Well, again, look, older patients, performance status 0 to 2, very high-risk diseases, secondary AML and AML-MRC. And we've seen in older patients, where there's many, many more patients that are eligible for transplant, you can see very good survival data in patients exposed to the CPX. And look, the transplant rate goes up. And if you don't transplant these patients, although the outcome is better compared to 3+7, it is not better than having a transplant. So having a transplant, if you're exposed to Vyxeos, is better than not having it. So in fact, what the Vyxeos data, I think, shows us is that if you can get that patient elderly, where the disease prevalence is high, to a transplant, then that patient's going to have a very good long-term survival. And that's survival. That's not progression-free survival, event-free survival, response rate, CR rate, MRD negative rate. That's long-term survival. And then if we look at safety, so hay was made about the safety of the transplant procedure. Well, look, in the patients who got standard daunorubicin cytarabine, there was a 30-day mortality of 10%, lower in the Vixios group, a 60-day mortality of 21%. To me, that's quite high. And you might say, well, the transplant-related mortality is quite high. Well, let's look at that. 100-day mortality after a transplant is under 10%. So that's 3 months later, not 1 month or 2 months later. Of course, it's slightly higher in the patients who were exposed to standard daunorubicin. But let's look at the UK. So this is UK national 100-day mortality data, all cause, is 10%. So I think the argument for transplants being potentially unsafe, I don't think holds much water from the national data that we all contribute to. Let's look at the relapsed refractory setting. We've got lots of specific types of drugs which we know are not that effective because AML is a very heterogeneous disease. And we can see that the data for gilteritinib, although not very impressive, does increase the number of patients that you can get to transplant. So more patients can get to transplant. Look at the data for the IDH1 inhibitor. Again, not many patients are alive at this time point. And there are a couple, there's 4. Oh, but look, some patients did get to transplant. Oh, that's right, so they're alive. So you can see that actually what transplant can give you is cure. You don't need surrogate markers to know because your patient's going to have long-term survival. And I think it's important to remember that that cure is both for patients that need consolidation, but remember, transplant is still probably one of the most effective treatments for relapsed refractory disease. We already know, so it's my penultimate slide, we already know that patients with good risk disease aren't transplant candidates. I'd like to just remind the opposition about that. And then if I finish with showing you the UK data on long-term survival with a transplant, both in CR1, not in CR1, a second transplant, and also for patients who are having a salvage transplant. You can see long-term survival is pretty good. So with a reduction in non-relapse mortality, particularly as we go forward, I'd like to finish by saying that advances in diagnostics and new therapies actually increase the need for transplant.
Thank you to Amit and the 4 speakers. I hope both teams have nominated their summer-upperer. We've got 2 minutes, which will be absolutely religiously enforced, and I shall ask you to stop when we reach 2 minutes.
I think we've had an interesting experience today. We've heard a lot about the tsunami of new therapies, and I would caution you to listen to random comments from the audience. It's a bit like Twitter. We need to be consistent in terms of how we embrace these new therapies. I think I gave you 4 clear drugs where there's unequivocal evidence that the need for transplantation has been reduced. We're not talking about a global total number of transplants. Yes, we've got an aging population. There's more people getting AML, more people having relapses, more people having salvage therapy. There's bound to be more total numbers of transplants. But the general need for transplantation has been diminished unequivocally by the sophisticated diagnostic techniques as outlined by David and these new therapies that clearly will allow quality, long-term survival for patients, a cure without graft versus host disease, and a cure that everyone could appreciate. Thank you.
Thank you, Mike. I think that was the proposing statement. And to oppose, to sum up, Rachel.
Okay, let's just step away from the motion for one moment and focus on what we're all actually here to do, which is to cure patients with leukemia. Now, that is the aim of the proposition and the opposition. It's just we've shown you evidence that we can do it better. What evidence have the proposition provided in support of their motion? And it was actually the proposition who kept fiddling with the motion, not us. So what evidence have they given us? Well, first of all, they've told us that MRD means we don't need to transplant some patients. What I would say is that MRD analysis and better understanding of that allows us to better risk stratify patients so that some patients who may conventionally have been regarded as needing a transplant will not need a transplant. We accept that. But there is still a proportion of patients who it will identify as needing a transplant who would conventionally not have been considered as high risk. They've also told us that we can avoid transplanting patients who have futile transplants, those with TP53 mutation. Well, I would suggest that we should be going a step further and being more enthusiastic and more ambitious. We should be looking in those patients at using new agents like the TP53 reactivator APR246 to bring about more remissions and get those patients to a more successful transplant, combining other agents and not having such a nihilistic approach. They've also told us that we can avoid transplanting patients we wouldn't transplant anyway with novel therapies. And what have we done? What have we shown you? Well, we've demonstrated that there is no evidence currently to show that the need for transplant is reduced by new advances in diagnostic techniques and new therapies. We would propose instead combining these agents, just like Charlie's going to do in COSI and Amadeus, and please vote against the motion.
So just to remind you of the motion, in case you need reminding, if you're voting in favour of it, you're suggesting there will be less of a need for transplant. If you're voting against the motion, you're either saying as much or more need for transplant. So over to you. Thank you, everyone.